My name is Jody Gutkin, and I will be your presenter for wrist and hand disorders. I have been a physical therapist for 28 years and involved in physical therapy education for over 20 years, and I look forward to discussing this topic with you today. The focus of our course is to take a look at the pathologies that are presenting below the wrist, focusing on the wrist and hand area and the region below the elbow. We're going to take time and look at the pathophysiology of the different conditions, as well as the arthrokinematics and diagnostic tests that are utilized. We'll spend a lot of time connecting all of that to the clinical presentation that you will see. The intent of this course is to have us really take a minute and pause and look at the similarities and differences among these different conditions so that we can recognize the different rehabilitation considerations as we're working with our patients, and to focus on the current research to see what the trends are related to these pathologies. The goal is to ensure that we distinguish the different conditions if you're differentially diagnosing or treating a patient who may or may not be progressing, that we understand the different nuances between the clinical presentation and the development of these different pathologies. Also, if a patient is not progressing appropriately, so that you're prepared to have that conversation with the physician about the diagnosis and how the patient is progressing. Everything that I discuss is based on the current research trends, even though there may not be a reference on every slide. All of the references are provided for you at the end of the course notes packet, so you can go back and look at those if you want to delve a little deeper into our topic for today. The focus is not so much on management of these conditions. It's to have us understand the development and the clinical presentation so that we can make the appropriate clinical decisions. I will go over any particular trends or pearls that came up in the research related to each condition, though. That will be important for you to recognize during your rehab. As with any course that you attend, when you go back to apply this information in the clinic, you are going to do so in accordance with the federal, state, and professional regulations where you are practicing. You'll notice throughout the slides that there are several that have this blue icon on the bottom right that says "Consider this." That's to let you know that those particular slides will be helpful when you go to complete that post-test later on today. We're going to be examining closely wrist and hand function and the different pathologies that impact this region of the body. I want you to consider, as we're discussing this today, not only those patients who present with specific wrist and hand pathologies, but also consider individuals who have neurologic pathologies where maybe their hand dominance has now had to change, and they might develop a pathology because they're using their non-dominant hand. Think of individuals who have needed to change their work environment, so now they're using their hands differently for prolonged periods of time. Also look at individuals who maybe now are utilizing an assistive device or a wheelchair as their mode of locomotion. So they're using a lot more of their hands as opposed to their lower extremities, which may lead to the development of certain pathologies. I want us to look broadly at all of those different populations as we look at our topic for today. We know our basic wrist and hand anatomy. We will have our carpals, metacarpals, and then our phalanges. We have very specific joints throughout the hand that are going to allow that fine motor coordination as well as gross motor tasks to be performed. And the alignment is very important as we look at the lines of pull of the different muscles and the alignment of the different bones of the hand. I always have a fond little giggle to myself when I come up to the point of talking about the carpal bones. We all have all those little mnemonics we made up during school. Apparently, I was always hungry. You'll hear throughout today that many of mine are related to food. When we look at the carpal bones, they are designated into a proximal as well as a distal row of bones, and they all have very intricate articulations with each other to allow for that function of the hand. The hand needs to be able to sustain loads during weight bearing, perform our fine motor tasks, and then also to sustain distraction forces as we're carrying different objects. When we look at our carpal bones, my mnemonic starts here on the pisiform and goes counterclockwise. So mine is PTs love Sundays, 10 toppings, can't hurt, which represents our pisiform, triquetrum, lunate, and scaphoid in our proximal row, and then our trapezium, trapezoid, capitate, and hamate in our distal row. Other articulations that are important when we look at the distal upper extremity, when we say wrist joint, it's not really accurate because it's not one specific joint. We have our radiocarpal joint, our articulation between that distal end of the radius and the scaphoid and the lunate. We also have our distal radio-ulnar joint articulation, and all of these are important when we look at functioning of the hand. Any slight change in the angulation could have significant impact on the ability for the individual to perform functional tasks with that hand. As we look at the arthrokinematics, normally we have our flexion extension, radial ulnar deviation, and pronation supination of the wrist and hand. This was identified long time ago, and we frequently are measuring our goniometry of the wrist and hand to have those objective measurements to see the patient's current status as well as progression. When we consider the two different ways to measure wrist flexion and extension, one method is to measure across or along the lateral region, or I should say, technically it's the medial region, I should say along the ulnar side of the hand. And in this respect, the research says that when you're measuring the goniometry this way, it's looking more at that articulation between the hamate on the ulnar side of the hand, versus if you measure across the dorsum of the hand. That measurement of goniometry has also been proven to be accurate and reliable, and that's looking more at the radial side carpals and their articulations and contributions to wrist flexion and extension. The research says that when we're considering goniometry, either way can be utilized, but it has to be utilized consistently. So we should consider that based on which carpal bones the pathology involves, that we may measure one way versus the other, or maybe you decide you want to use both to delve a little deeper into the arthrokinematics. As we consider functional task analysis, when the research is looking at different components of movement, there are several standards that they try to develop. They use different silicone gloves and computer technology to try and see for brushing the teeth, feeding, what are the standards of goniometry. And we know when we're setting our goals for our patient, we want to have functional related goals. When I was teaching in the classroom kinesiology, I would always say, well, for example, how much range of motion is needed for someone to weed their garden? And students would be, trying to figure out how much wrist flexion is needed and what position. And I would always come back and say, okay, well, I'm your patient and I need wrist extension. And they couldn't figure out how that happened. I said, well, I'm writing a check. Maybe now I'd say finger thumb flexion because I'm sending that payment over my phone because I have a gardening service. It was just always a little aha moment to say, well, we do need to consider for our patients how are they performing functional tasks and what is normal for them and what's necessary in our goals. Feeding is another great example of that. When someone's eating, are they utilizing a fork and knife? Are they utilizing chopsticks? Maybe they're eating with their hands. Also consider typing. Are they typing on a full keyboard? Are they typing on their phone so it's more the thumb? We want to consider all of this. When we look at individuals who are utilizing a wheelchair for their primary method of locomotion, they're relying more on their hands now versus their lower extremities for locomotion. And it has been noted that 73% of individuals who utilize a wheelchair are prone to developing carpal tunnel syndrome at some point. And this is important for us to recognize. So in our discharge planning with patients, we include education to hopefully minimize that risk for them down the road, or at least an awareness so they can seek intervention as necessary. When we look at the structure and function of the hands, as we analyze the bony anatomy, I read an interesting article where they took some time and they looked at the morphological development of the hand over time. And they recognized that as cranial capacity increased, and upright posturing, so did the change of the structure of the hands. So that when we make our fist, if we notice that fifth metacarpal is shorter, well, that was better at holding a club and wielding it. And that fat pad increased on that hypothenar eminence to give some force distribution during that. We have more of a power grip, 3-draw chuck from the metacarpal and carpal metacarpal joints to allow for, they said, wielding of stones and hunting and gathering. Just a nice way to remind us that structure dictates function, and we do need to have appropriate movement and alignment among all of these joints for our patient. More recently, what's become recognized is the dart thrower's motion. And this is looking at another plane of movement in the wrist and hand, and it's as if you were throwing a dart. You're moving from a position of radial deviation and extension to ulnar deviation and flexion. It's also, they say, if you're conducting in an orchestra or fly fishing, hammering, to give you an idea of the movement pattern. And what they're finding is, I kind of think of this as the scaption of the wrist. That's just my way of thinking of it, because it's about that 30 to 45 degrees off of the sagittal plane, this wrist motion. And what they're finding as they analyze this, that it's utilized frequently in a lot of different functional tasks. And what happens is the proximal row of carpals tend to become stable with the wrist articulation. And then that distal row of carpals at that mid-carpal joint is where the movement is actually occurring. They looked at the proprioceptors, and they found that those proprioceptors in the ligaments for stabilization were not present, that the proprioceptors were more located in the ligaments that stabilize that mid-carpal joint and those carpals that move in the dart thrower's position. And that is relevant because those proprioceptors are what trigger muscle movement and give feedback for those different movements. Recognizing that the movement occurs more at the mid-carpal joint, you might start seeing that some patients post-surgically, or depending on their pathology, that the physician earlier will allow range of motion in this dart thrower's position to try and maintain some movement and glide of the carpals while still protecting their proximal row and that wrist articulation. In terms of goniometry for this motion, the research isn't there yet. They're still trying to figure out the best way to measure it. One recommendation was, when utilizing the goniometer, to place it along the radius and then along the second metacarpal and kind of measure in that diagonal position. They compared actual optical analysis and computer calculations to clinicians measuring this range. And even when they utilized hand therapists who are more precise in these measurements, they did find an 8 to 16 degree standard deviation in measurements. So the recommendation is, if you are goniometrically measuring this, to have the same clinician do it to help give more reliability to the information. We also have a significant amount of musculature that contributes to our hand function. We have those muscles that originate outside the hand, yet insert inside the hand. So those are our extrinsic muscles. And then our intrinsic muscles that originate and insert inside the hand specifically, that tend to be utilized more for our skilled movements. Imaging techniques are important when a patient presents with a pathology, for the physician to gain information on what structures are involved and confirm the diagnosis. There are several different imaging tools that can be utilized. First, most basic one is the X-ray. History of the X-ray is that it was developed by Röntgen going all the way back to 1895. This is the first X-ray. You can see his wife's ring on her hand. This is going to allow imaging of bony structures. It was originally named X-ray, X representing the unknown. And just a side note on this, it was never patented, even though he did win Nobel Prize for its development. He donated the money to charity. He never patented it. Great for society and medicine. However, he did not reap any of the financial benefits of this great invention. X-rays might be utilized for skeletal age assessment, and I added in here because it's the hand that is X-rayed. So if you're working with pediatric populations for multiple different diagnoses and they just happen to mention that they're going for a X-ray of their hand for some reason that doesn't fit a specific trauma or diagnosis, they might be trying to assess skeletal maturity. And there are a couple of different grading scales that are utilized that I mentioned here so that you have that information. There are several reasons that they might look at skeletal age. Oftentimes, they're trying to get more information if the individual presents with an endocrine condition, if they have low functioning of the thyroid gland, or extensive use of corticosteroids. Both of those may reduce cellular division and proliferation, particularly at the growth plate, that is going to change the ossification of the carpals, which is normally slower than other bones. So they're looking to see kind of like a chronological age for the individual and what their bone age is compared to that. So it's also utilized when birth records are not available. If you are working with individuals who have maxillofacial pathologies for dental implants, they want to make sure that that skeletal maturity has been reached of the mandible, and they can sometimes utilize that X-ray of the hand to gather more information about that to see when permanent dental implants could be safely utilized. As we compare utilization of the X-ray to the CT, specifically considering injuries to the hand, they've done studies where they used sections of cadavers and they randomly created fractures of the carpals. And then they performed X-rays and CT scans and randomly gave them out to different physicians to see their diagnostic readings if they were able to recognize those fractures. And if we look here on the left, the X-ray, just above this line I drew, you can very faintly see the fracture. But on the right-hand side above that line, which is the CT scan, it could much more clearly be seen. And what they found when they compared the physician results is that the diagnostic accuracy and the clinician confidence was similar for many different regions of the extremity, except when it came to those carpals, that oftentimes that X-ray is missing those carpal fractures. As we look at X-ray compared to more of a 3D image, the MDCT is taking multiple images to create a 3D representation. So on the right-hand side, just above my line, we can see the fracture, and then on the left, we can see it much more clearly. Oftentimes, the X-ray is utilized first because it has a lower exposure to radiation than a traditional CT. But these newer techniques are taking much faster slices, so it's less radiation exposure and giving a cleaner image to try and catch these fractures sooner so that a patient isn't immobilized or a fracture missed that can be leading to additional complications. It may allow for earlier diagnosis. I couldn't find an image for this of the hand, but this represents how the SPECT-CT is being utilized. When the CT scan is done, it gives a great representation of the anatomy in the area. The PET scans are going to give feedback on metabolic activity. When the two are put together, we can see it gives a good combination to see where pathology lies. For the hand, they're looking at utilizing this to try and gain more information about metabolic activity as it relates to pathology of different tissues to hone in a little bit better on diagnosis. The challenge is holding the hand in the position long enough. They're trying to come up with equipment that allows that so that the PET scan component can be done accurately. MRIs are often utilized to correlate with the clinical presentation. Some studies say that if a fracture is initially not seen on x-ray, particularly of those carpal bones, and the patient is presenting to us with continued pain, range of motion restrictions, that the next test the physician orders is likely going to be that MRI to more clearly see those soft tissues as well as the bony structures to try and identify those pathomechanics. Active MRI is emerging as a beneficial tool. As the wrist and hand is utilized, there are so many moving parts to it, and the soft tissues also shift significantly. They're looking at more active range of motion techniques that creates more like a movie as the patient is moving, for example, from radial to ulnar deviation, so they can see, particularly with carpal instability, where as they're shifting, where the pathology lies. When an individual is presenting more with a neurologic presentation where there is potential of nerve compression, they're going to go for electrophysiologic studies. This is now our umbrella term that is going to incorporate our nerve conduction studies, previously referred to as nerve conduction velocity, with the surface electrodes that are going to be placed to read how quickly the impulse is sent down the nerve to give an idea of where there might be compression that's limiting function. And then EMG electromyography is looking at that needle electrode in the muscle to actually sense that activity and response to the innervation. And it's great to see the progression over my many decades in the field. I remember way back, I was fortunate to be in a teaching hospital working side by side with physiatrists, so I was able to be part of these tests. And now in certain states, physical therapists can actually perform these interventions with additional training. So you can check the restrictions and opportunities in the state where you practice. Ultrasound is emerging as really beneficial for diagnosis of certain hand pathologies. The benefits are that this is low cost, it can be performed in the office, the high resolution. I Googled ultrasound of the hand, and what came up is this little baby waving at us. But it illustrates well that the hand structures are very apparent, particularly if we were to isolate the ultrasound of the hand. Some additional benefits are that the ultrasound can distinguish tendon sheath from tendon because of the differences in the collagen content. And then also, if someone has a compressive neuropathy, that overpressure from the ultrasound head can be utilized to replicate compression to actually see what's happening and get the verbal feedback from the patient as to what they're experiencing. So not only can you visualize the nerve the whole length, that you can get the benefit of patient feedback. They can actively perform motion and see the different response of the tissues, and we're not concerned about the radiation exposure. They're looking at this dynamic type of imaging using nerve ultrasound and are working on establishing norms of what position should nerves be in, how should they be moving. And one example is this was a study where they had the individual on the top in a position simulating movements as if they were texting, and they were ultrasounding to look at that median nerve. To orient us, across the top here in this bottom image, we are seeing the transverse carpal ligament, that roof of the carpal tunnel. And we see our lunate curves here in the bottom. What we see dotted out here is that median nerve. And the nerves, when they're on ultrasound, they kind of look like a honeycomb or netting because they have that fat tissue in between them. And they can actually look, as individuals are performing movements, what forces are exerted on the nerve and if any pathology is resulting. In the clinic, what we look at to replicate some of this and give us more information are different provocative tests. We are going to utilize different movements, different forces applied to the joints and the tissues to deliberately try and provoke them to give us confirmation on what pathologies are presenting. We're going to specifically take a look at several different categories of involvement. We'll discuss nerve pathologies, followed by tendon and fascia, move on to our bone and joint pathologies, and finish up with ligamentous involvement. As we look first at our involvement of nerves, terminology is important and consistency is always necessary. Oftentimes, when it comes to nerve involvement, certain terms are utilized interchangeably, which may not really be accurate. The terminology that I'm presenting here is what seems to be consistent between the American Academy of Orthopedic Surgeons, the different researchers, as well as disciplines. If we look at the right-hand side here first, discussing peripheral neuropathy. This is going to involve more than one nerve. It's a polyneuropathy, tends to occur in individuals who have systemic disease or neurological conditions that are affecting the microvasculature and that supply to the nerve. Examples with diabetes, alcoholism, toxicity, chemotherapy, where we're seeing a symmetrical, usually distal and chronic presentation. Where we're focusing today are going to be on our compressive neuropathies on the left-hand side. This is involving one specific nerve, and it's either space occupying, something else is in the space where that nerve should be passing, or the structures inside that tunnel have enlarged, compressing on that nerve, and our clinical presentation will be very specific to the nerve that is involved. The structure of our nerves that we're looking at back in school, young and not thinking clearly, I'm like, oh yeah, nerve. It's just one little strip of tissue. No, that's not exactly how it is, and that's what makes nerve compression so complicated. When we look at the different layers of our nerve, we have our different fibers, motor as well as sensory. Those are grouped together and they have tissue among them and fat layers in between. There's a vascular supply running intimate with the nerve because itself needs nourishment. And this is why when we have a compressive neuropathy, we'll see a specific presentation. And it's also why the longer that exists, the more ischemia that's happening to the nerve. It's just not a matter of, unkinking the straw or unkinking the hose and the flow is back. If there's ischemia that has happened and compromised to the different nerve fibers, there may be more permanent loss of function. When we look at different space occupying lesions in the hand, one of the most common is a ganglion cyst. They tend to happen more on the dorsum of the hand, but they can happen in different areas, tend to come and go. There's not really agreement as to what makes it happen, but they have found in the research confirmation as to what exactly it is. When they go in this second image and look, we see a very clear kind of bubble of tissue. And on imaging on the right, It's described as a stalk coming out of either the synovial layer of a joint that's been damaged or a tendon sheath that has been damaged. And then on top, we see a balloon. What I'm seeing is an ice cream cone, food again. I think it's kind of a easy way to explain to patients what's happening, that there's a projection coming out, and when they actually look at the fluid, it is a synovial-like kind of viscosity fluid. So sometimes draining it works. Other times, if it is not successful, surgical intervention may be necessary to remove that actual communication and pouch so that it doesn't refill for the patient. While these are present, if they are in a space where nerves are located, it can compress them, leading to pathology. If we look on the palmar surface of the hand, examining our flexor retinaculum, we have our flexor retinaculum that will come across and look at attaching to create that hood of our carpal tunnel. And within here, it's resected out here. We can see the rough edges of where that flexor retinaculum has been opened up. And then we see this large grouping of tendons from our finger flexors, as well as that median nerve that are needing to pass through that tunnel. Now, each tendon has its own sheath to glide in. And then among those, there is another kind of sheath, and in between all of those tendons in it, there's a subsynovial layer of fat that allows for additional gliding and significant friction absorption to help minimize the stress and tension on the tissues that are occurring with every activity that's done of that wrist and hand, because this is a closed compartment. What we need to recognize is also within there is a vascular supply and that very important nerve. So when we consider the pathology of carpal tunnel syndrome, normally the hood holds this in place so the tendons don't bowstring. That means they don't fall out, so it allows them to maintain their mechanical advantage. And then within this grouping, we have that subsynovial connective tissue that allows for gliding and absorbing of the friction force. It was first recognized in 1854, and today carpal tunnel syndrome is the most common compressive neuropathy that individuals are presenting with. There are many different etiologies. It is not just someone with more of an orthopedic type pathology, that overuse condition that we'll get to. Also, consider other patients as you treat them for these diagnoses and look at wrist and hand and what may be going on with them. What they're finding is there can be traumatic carpal tunnel syndrome if there's a shifting of the different carpal bones, particularly lunate, that subluxes out, or associated with a wrist fracture. Some individuals who present with diabetes. But they're finding individuals with diabetes, you need to distinguish that peripheral neuropathy from potential compressive neuropathy, such as carpal tunnel syndrome. The metabolic activity that they're recognizing of collagen turnover in individuals with diabetes, particularly of the tendons in the carpal tunnel area, is altered. That may change the bulk, leading to the compressive neuropathy. With hypothyroidism, they're noting that there are excessive fat deposits. And then individuals with pregnancy, particularly in the third trimester, the excessive fluid in that region can lead to carpal tunnel syndrome, as well as our space-occupying lesions. And another population I want to highlight is individuals who have hemophilia and those on anticoagulants. Our patients who are ambulating with assisted devices, or those who are not, that have lower extremity or back pathology or balance deficits for neurologic reasons, and maybe they're on anticoagulants and they have a stumble and a recovery with their upper extremity, or a fall where they land on the upper extremity. Often the first assessment is, yes, is the head protected? Is the other regions protected? Was there a wrist fracture? Well, down the road, those individuals may start to present with carpal tunnel-like symptoms if there has been bleeding out into the carpal tunnel that now is placing a compressive force on that median nerve. And then we do have individuals with functional tasks who are at risk of developing carpal tunnel syndrome. The American Conference on Governmental Industrial Hygienists, which sounds like an amazing place to work, that would be bucket list for me, that they recognize that there's a high probability of work-relatedness to the development of carpal tunnel syndrome, particularly with certain combined exposures. Now, historically, it was thought that the use of the computer was contributing to the development of carpal tunnel, but the epidemiologic information is not supporting that. Same thing with cashiers. It's just not supporting that. What they're finding is it's more two factors. The first being hand force, that individuals who are exerting greater than 8 pounds of force with their hands, and they have excessive repetition of the tasks that they're performing. So the work cycle time of the activities that they're performing of the wrist and hand is less than 10 seconds, so it's repetitive, or they're holding statically in one position for greater than 50% of the time. These two combined exposures seem to increase the risk of development of carpal tunnel. And then vibration, we're finding, is traumatic to the hand in many different ways. That the vibration forces alter the microvasculature in the hand. They put excessive loading across that carpal tunnel. And when you put all this together, particularly, it increases the risk of development of carpal tunnel. That extends the populations that we are considering who might be at risk. Individuals who are doing carpentry, roofing, jackhammers, even more fine motor, if the person uses any tools, such as if they're a nail technician or a dental hygienist. These are opportunities not only for education, but for us to be aware in our rehab that we need to look at maybe some ergonomic and work modification to limit the redevelopment of carpal tunnel. Historically, carpal tunnel syndrome was always considered to be an inflammatory type of condition, and that's not the case anymore. It is not recognized any longer as an inflammatory condition. What we're seeing is individuals who perform these repetitive types of motion, they develop excess shear strain across those tendons in that carpal tunnel. So as those tendons become slightly damaged from the work involvement or recreational task, they are going to attempt to heal themselves. In doing so, as those tendons are healing, it tends to be more fibrotic tissue that develops. It has a lower threshold tolerance to the shear stresses with movement. And then it is going to also increase in its bulk in this tendon as it's healing. If we have that increased bulk with the synovial thickening, that subsynovial connective tissue being compressed in the area, vascular supply to those tendons themselves being altered, further perpetuating this cycle, all of that leads to a greater compressive force in the tunnel, and that's what leads to that ultimate nerve compression for the individual, that every time they move. So it's not really an inflammatory conditioning, it's more a bulk type concern. Looking at ultrasound images where they analyze what's actually happening to that median nerve in the carpal tunnel, we tend to think of it as more of a longitudinal glide that the nerve needs to move. The reality is we have all these tendons shifting in there with all the different motions that occur of the wrist and hand, that not only does it need to translate longitudinally, it needs to move transversely. And when everything becomes bound down in that connective tissue, that further restricts the glide and perpetuates this cycle. Or if it's a space-occupying lesion, it leads to more challenges for that nerve to move. If we look at this study where they had the individual with their hand out and they just had them opening and closing their hand, moving position here. The first image on the left, let me orient you. We have our radius and our ulna, our roof here of our carpal tunnel, and our nerve. So our nerve position is moving significant when there is no restriction. This is normal. As we look at the glide of the nerve in someone who is presenting with more of a mild carpal tunnel, we see it's gliding a little bit transversely, but not as much. It's bound down. And then this is someone with severe carpal tunnel syndrome. That nerve is not gliding at all. So you can imagine the additional stress that's placed upon it and potential compromise and pathology the individual present with. This also helps us understand why nerve gliding is a beneficial intervention, and tendon gliding, that everything's becoming bound down. And I think recognizing that there is that subsynovial connective tissue that also plays a role further helps us understand why stretching, nerve compression, and nerve gliding can help release that nerve. As we look at the symptoms an individual presents with carpal tunnel syndrome or with any nerve compressive pathology, it tends to be a progression of symptoms. Initially, the individual experiences pain. Then, as there is additional compression and ischemia to those tissues of the nerve, we're seeing more altered sensations, tingling, prickling, pings and needles. That progresses to dysesthesia, or burning, and then anesthesia, the numbness and loss of sensation. And if progression continues further, we'll see motor weakness. When our patients present and we're asking them for those descriptors of how it feels, and someone may say, well, I can't feel it. Well, what does it mean? Is it altered burning or loss of sensation? And we need to try and pin the patient down. When they say numb, do they really mean numb, or do they mean it's more tingly sometimes and they're feeling that instead of what they're actually feel like they should be touching? This is going to give us some feedback on the initial presentation, and then also if we're making some small gains in our releasing the compression on the nerve, we should see this go backward in restoration of some of these sensations. The specific clinical presentation for individuals with carpal tunnel syndrome are going to be that numbness, tingling, burning, pain, and sensory changes of the hand. Often the individuals want to shake their hands. They complain of it at night, actually waking them up when it's more progressed because of this compression along that median nerve. The specific location of where we see the sensory changes is important in our assessment of the patient when we're doing sensory testing. We typically think of all of that index, middle finger, and thumb area as our distribution for that median nerve. If we test it out more specifically, what you are likely to find in carpal tunnel syndrome is that we see more of a isolated preservation of sensation in this area that I'm coloring in here, in that thenar eminence. The reason is when we look at the median nerve branching off here, the digital branch goes through the tunnel to provide sensation to the digits, but the palmar branch goes over the tunnel, so that tends to preserve that sensation in the region. Motor involvement that we're going to see is going to be specific. Meatloaf is an abbreviation, so we have meat being our median nerve, and we will see involvement of the lumbricals 1 and 2, which lumbricals 1 and 2 perform MCP flexion for the patient. That's why when we have a patient with their hand open who presents with median nerve compression and we ask them to try and close their hands, we'll see what's called a benediction sign, where the ulnar digits will flex, but the index and the middle finger will not because of that lack of the lumbrical. The key here to see benediction is that we're asking them to close and they're unable to do that. We also tend to see when this is more progressed, this lack of musculature in the thenar eminence, of that thumb tending to fall away from the hand into our ape hand position. This is because loss of innervation to that opponens pollicis, abductor pollicis, and flexor pollicis, our oaf of loaf, leading to that ape hand where it is falling off to the side. When you see that significant thenar atrophy, you should be thinking carpal tunnel syndrome, but if that doesn't present, it doesn't mean it's not carpal tunnel syndrome. It just may not be that progressed at the moment. Individuals are going to present with weak grip and pinch. They'll tend to have clumsiness of their hand. Maybe they say they're having difficulty opening jars, closing buttons, things of that nature. Looking at our provocative testing for the median nerve in individuals who are presenting with carpal tunnel syndrome, Tinel sign we know is when we tap over that nerve, it's going to replicate those symptoms for the patient, and that can be done for a lot of different nerves at different locations. The Phelan's test is where we are going to give an overpressure into flexion for 30 seconds to a minute. And if we see replication of those symptoms as we replicate compressive forces across that tunnel, it is helping us confirm that diagnosis of carpal tunnel. For those of you who are utilizing neural tensioning of the median nerve, attention needs to be paid to, as you're putting the patient through the positions of abducting and externally rotating the shoulder, extending the elbow and supinating, and then moving into the wrist and hand positions to see how and when their symptoms are increasing. For the median nerve, looking at compression at the wrist, there's a possibility that it could really be a cervical pathology as you're taking them through all these different positions, particularly if the symptoms increase when you add that head and neck component. It may lead us to believe that it's more proximal versus in the wrist where the compression is occurring. And that differential diagnosis is important to make sure that we're targeting the appropriate area with our interventions. Patients presenting with cervical radiculopathy of C6, C7 will also present with that median nerve compromise that will be similar to a carpal tunnel presentation, but we're also going to see increase in symptoms with that change in head and neck position. And when you do your reflex testing for the biceps, triceps, brachioradialis, if the compression is more proximal, then we're going to see alterations in those reflexes also. Lower brachial plexus injuries can also mimic the carpal tunnel presentation. And then again, distinguishing diabetic neuropathy, which will be more bilateral, symmetrical, that glove type sensory loss from the specific sensory loss, and motor weakness in carpal tunnel, which is usually unilateral unless they have a job that's similarly bilaterally. I really looked for some information to give us focus in terms of management. There was no one specific protocol that I did find. I was able to locate a 2018 Cochrane review where they pulled together all the different research studies. Some commonalities that emerge is that nonsteroidal anti-inflammatories and diuretics are not beneficial, as well as acupuncture did not show a benefit. Corticosteroids did show some positive effects for individuals. When we look at those activities that did show some relief of symptoms and improvement, the stretching, strengthening, and soft tissue mobilizations, including that tendon and nerve gliding early on, combining with splinting, did show benefits for patients, and then progressing them over the weeks where you're weaning off the splint and adding strengthening as well as functional tasks. When they compared trigger point work to friction massage and other manual techniques like the Graston technique with exercise and stretching programs over a course of 6 weeks, no one combination emerged as most beneficial for the patients. Splinting has been recognized as beneficial for individuals with carpal tunnel syndrome, though the specific type of splinting and the length of it, there is some variability on. The key is to keep the wrist in more of a neutral or cocked up position to avoid that compressive flexor force across the wrist. And this is a very ancient times model, but they even realized that back then that excessive flexion created increased mechanical loading that needs to be avoided. Interesting study that I read, a little disheartening as a clinician, but good for the patients, is that they found that the use of splinting, even in the absence of therapy or rehab in some patients, over time was successful in alleviating their symptoms. So just removing that mechanical loading, which I think would translate into combining that with therapy could give extended benefits for patients. Moving up a little more proximally in the extremity, we'll look at a couple of other nerve compressions that you want to be aware of. The anterior interosseous nerve syndrome. This is a branch of the median nerve. It's emerging in the proximal forearm. If we look near the pronator teres muscle and the bicipital aponeurosis in this region here, I'll draw it out in our image. We'll circle it here. We will see this tiny branch of the anterior interosseous nerve that comes off. This is going to go down to innervate our flexor pollicis longus and our index and middle finger flexor digitorums. Several different mechanisms of injury that can exert a compressive force. When someone has particularly a supracondylar fracture of the humerus, as it's exiting in this region where the nerve is, it could compromise that nerve, penetrating injuries in this region. And also, if you consider this is where many venous punctures go in. So patients who have many blood draws, they tend to develop more fibrous tissue in the area that can wrap around and compress this particular nerve. Also, patients who have undergone surgical procedures, if there is a tourniquet that's applied for a prolonged period of time, can lead to compression of the nerve, as well as our compressive pathologies, a space-occupying lesion of a lipoma, a fat tumor, or ganglion cyst. If they have a pathology where compartment is increasing in its swelling, and then also a cast pressure. If you're in acute care or even home care or outpatient where we're seeing those acute care patients sooner post-surgically for more proximal surgeries and they present, as we're going to discuss, it might be that there was excessive pressure during surgery. So these patients may need some adaptive equipment temporarily until their sensation and mobility returns. The way that we're going to assess for anterior interosseous nerve presentation, noting that they tend to have kind of like poor, vague expression of pain in this anterior region of the forearm. The reason that occurs is this is purely a motor branch of the nerve. So there really isn't a sensory involvement or a nociceptive involvement. That kind of dull pain may be related to other tissues in the area as that are irritated based on whatever is causing the compression of the nerve. You're going to ask the patient to try and make the OK sign. And if they are unable to do this appropriately, make that clean circle. This is going to let us know that they're going to have some weakness of their musculature that is innervated by the nerve. We're going to look at that flexor pollicis longus as a culprit for not allowing the OK sign to be completed appropriately. If you have patients maybe with rheumatoid arthritis or another pathology where you think there might be rupture of that flexor pollicis longus tendon, you want to do a tenodesis to make sure that that tendon is intact, and that's not what is causing the inability to make the OK sign. That is truly a motor weakness from that more proximal compression of the nerve. In terms of functional tasks, this might be your patient who is complaining of difficulty with those fine motor kind of pinching pad to pad activities, writing, buttoning type activities. Posterior interosseous nerve syndrome is going to be compression more proximally on the posterior aspect in the supinator region. This is involving our radial nerve. When we look at where the radial nerve is coming down from the humerus and it's going to bisect through the heads of the supinator muscle, as it emerges as the posterior interosseous nerve, it can become compressed. It might be a space-occupying lesion, like in the right here. We see it on the scan, and then the actual size of this lipoma for the patient, reminding us that when we're palpating, we need to know what we're feeling for. Are we feeling scar tissue, bony tissue? Could it be a lipoma? Could it be a ganglion cyst? So for this patient, that's what was causing the symptoms we'll discuss. Other patients, if it's not specifically a space-occupying lesion, it might be a trauma to the region. It might be that the muscles of that supinator, if they become thickened and hypertrophied as that nerve is trying to pierce through it, it can create a compressive force along that nerve. Individuals who have work tasks where they're doing a lot of supination, bodybuilders sometimes, that it may lead to hypertrophy and compression. Also, individuals who have had a radial head fracture or a displaced radial head, this can compress onto that nerve if the biomechanics are inappropriate in the area. And it may be, months, years down the line that they're starting to present with this insidious onset kind of tenderness in that region. The clinical presentation for posterior interosseous nerve syndrome, again, we're going to see that sensation is going to remain intact. However, the individual will present with pain because there are nociceptors located in this branch of the nerve. The pain that the individual presents with is going to be in that similar region where one would complain of discomfort with lateral epicondylitis, which is part of our differential diagnosis for posterior interosseous nerve compression. And you can imagine a nerve compression versus a lateral epicondylitis are going to have two very different paths in terms of management. So it's important that if you're treating your patient for lateral epicondylitis and they're not progressing as you thought, to take a closer look to see if it's posterior interosseous nerve syndrome. The hallmarks of that condition, where we see between the deep and superficial heads of the supinator, that nerve branch being compressed, if we palpate right in that area over the arcade of Froese between those heads, the patient's going to feel the compression and it'll replicate that tenderness that they are having. We're going to look at wrist extension for the patient. So this individual here, we're asking them to perform wrist and finger extension, and we're seeing that they are unable to perform that even in a gravity eliminated position. When we look at wrist extension purely for the patient, someone who has posterior interosseous nerve syndrome, it is the extensor carpi ulnaris and the extensor carpi radialis brevis that will have compromise as progression occurs. So they're going to lose those two muscles contributing to wrist extension. Well, they still have their extensor carpi radialis longus. So when you look at this patient performing wrist extension, even if they can only do a little bit, look at the quality. If you tend to see a little more of, a radial drift to their wrist extension, and if you go in and isolate out each of those muscles, it'll again help you hone in on the difference between posterior interosseous nerve syndrome from that lateral epicondylitis. Also, we know lateral epicondylitis, that resisted motion of the middle finger, is what's going to really replicate that pain and weakness pattern for the patient. As posterior interosseous nerve syndrome progresses, the individual is going to demonstrate weakness of the extensor indicis and the extensor digiti minimi. When you ask them to do the longhorn sign or the rock-on sign, they will be unable to purely get that finger extension to contribute to making that sign. And again, we're going to compare everything bilaterally to give us more insight. Nerve compression syndrome, moving on to our ulnar nerve. Now we're coming back down into the hand for our patient. We're looking at the ulnar side of the hand between our pisiform and our hamate is where we have our tunnel coming through for that ulnar nerve. Compressive neuropathy, sometimes it's referred to as ulnar tunnel syndrome, that entrapment between the pisiform and the hamate as it's passing through. We have a little hood over that tunnel. And this can occur for several different reasons. Always space-occupying lesions of cysts or lipomas are a possibility. Other space-occupying could be an ulnar artery aneurysm or a thrombosis. We're again considering those patients where they may be doing excessive weight bearing on their hands now, particularly with wrist extension and weight bearing on that ulnar side by that pisiform, where maybe they're propelling a wheelchair. Did they have a slip and fall where they're catching themselves? And it could potentially be a thrombosis in that area. I read a case of a patient who actually had a fall. They eliminated fractures, but they started presenting with symptoms, and it was a thrombosis in that area that was compressing on the nerves. More of our orthopedic presentations that you might see are any trauma that occurs to that area, to the pisiform or the hamate, kind of shifting the mechanics in there can compress the nerve. And overuse pathologies, one specifically called handlebar palsy. This would be our patients who are propelling wheelchairs, riding a bicycle where they're in wrist extension with weight bearing by that pisiform, or a motorcycle. What happens is every time that tire on the bike is going to hit the road, that force is going to be transmitted up into the hand. And in addition to the sustained force in that area, it can create trauma to that nerve, a neuritis, that will present with the Guyon's Canal syndrome. We need to differentially diagnose this from a cervical pathology for the patient, particularly if they're a rider. Oftentimes, we're looking higher up the chain, but it may just be the wrist position. I can tell you with my biking, I'm like a fanatic on getting the right handle grips and finding the right padding that has appropriate padding in that area. To be mindful of that wrist component, to not just be looking more proximally up the chain. The clinical presentation for Guyon's Canal can be varied. The reason is that as this nerve is going through the tunnel, it has motor and sensory branches, and the tunnel itself is considered relatively long compared to other regions where nerves are passing in the body. Depending on where this nerve is passing through and where it's actually compressed in the tunnel, you might see purely motor involvement, you might see purely sensory, or you may see some mixed motor and sensory involvement. So it may seem a little bit ambiguous, but as you go through, just recognize that it is because this tunnel tends to be relatively long, and depending on where exactly it's compressed, it could be motor and or sensory presentation. The clinical presentation that we will see for Guyon's canal is going to primarily have the patient complaining of weakness of pinch and grip. When we look at the muscles that are involved, the adductor pollicis, when you ask the patient to hold on to a piece of paper, the ferment sign, you're going to try and, pull that paper away from them. And if this is my involved hand, instead of adducting, I may start to flex to try and hold on to that paper because I'm substituting for that adductor pollicis, means an IP flexion instead. So that would be a positive ferment sign if that adductor pollicis is going to be weak for the individual. This is from a 1918 physician's textbook, where even back then, certain things over 100 years later, we still know it. That's why I find anatomy so amazing. We learn a lot, but certain things still hold true. Other presentation that you're going to see in an individual with Guyon's canal is they're going to lose innervation to the interosseous and lumbrical muscles. If we look at our pad and dab muscles, remember our palmar interossei are going to adduct, our dorsal interossei are going to abduct. So when we look particularly at the pinky and the ring finger, when the patient's hand is just at rest on a surface, Dr. Wartenberg found out that he was supposedly the Sherlock Holmes of neurology of his time. The interossei muscles, because they're impacted and you lose the adduction of the pinky. So imagine my hand flat on the surface. He noticed that patient's pinkies kept falling out to the side. You could passively put it back, but it would keep falling out to the side. And what he realized is that when you look at the particular line of pull of the extensor digiti minimi, when that remains innervated and it's unopposed by that palmar interossei to adduct, the resting tension pulls it out to the side. So this Wartenberg sign might be another indicator to you that it's Guyon's canal presentation. And then next we have our claw hand. Claw hand presentation may look very similar to the benediction sign. There are a couple of key differences. With claw hand, the intent is that you're asking the patient to open their hand. With benediction sign for carpal tunnel, we said they're trying to close their hand and the first two digits don't go. Now, with claw hand, we're asking them to open. And as they're opening their hand, what happens is we see hyperextension here at the metacarpophalangeal joint. So you have to look at it from this angle also. You'll see hyperextension in the metacarpophalangeal joint, and then they'll remain in flexion at the interphalangeal joints. The reason is the loss of those lumbrical muscles is not giving us that extension, full extension of the digits. Cubital tunnel syndrome is going to be compression of that median nerve ulnar nerve, cubital tunnel syndrome, as we're coming further up the chain. And we're going to look at compression here around that medial epicondyle for the patient. This can present for different reasons. If the patient has a pathology that may be a supracondylar fracture or a space-occupying lesion, sometimes it's transient based on their positioning where they're exerting a compressive force The way to distinguish the clinical presentation from Guyon's canal is if you're compressed up here with the ulnar nerve, yes, you're going to have that hand presentation that we discussed. You're also going to have more proximal involvement where you're going to see wrist flexion and compromise. Also, you'll see an exacerbation of the symptoms with that elbow flexion because it's going to irritate that nerve for the individual. What they're finding is that normally that canal is nice and round, and as we move into elbow flexion, it kind of becomes more of, they say, like a compressed triangle, which is okay if you don't have something else in there occupying the space. The fact that you lose about 50% normally. When you have pathology, that loss of space that naturally occurs with elbow flexion combined with maybe a space occupying lesion can exacerbate and lead to compression of the nerve. The sensory changes that we are going to see are going to be related to where that ulnar nerve is compressed for the individual. If we have nerve compression in Guyon's canal down here at the wrist, we're going to see a loss of sensation specifically to the pinky and ring finger. Here we go. When we have compression there. This is again because that digital branch of the nerve is going through the canal, so it becomes compressed. But the palmar branch and the branch that supplies the dorsal portion is going outside the tunnel. So that we're only going to see sensory loss if there is compression up here at the elbow. So understanding the anatomy, I've always found we don't have to memorize the clinical presentations. If we just understand where the anatomy is, it allows us to, or me anyway, to more readily kind of digest the clinical presentation of the patients. As we see more patients through direct access and coming in with different diagnoses, our differential diagnosis is even more important. Not only are we going to distinguish Guyon's canal from cubital tunnel, we're going to see if it's potential cervical radiculopathy. Is there compression in the thoracic outlet through that pec minor, first clavicle, first rib, all that differential diagnosis. And then additionally, I want you to be mindful of Pancoast syndrome. This is a combined presentation where individuals with non-small cell lung carcinoma, that as the cancer spreads to those apical segments and starts to metastasize out into that apical chest wall, very close to the brachial plexus, we start to see, we can, in the image here, the metastases up into that cervical plexus even. It initially starts to present as more of an orthopedic type presentation, or neurologic. The patient complains of radiating pain into the scapula, the axilla, particularly the ulnar nerve distribution that we just discussed because of the path the metastases takes and what becomes compressed in the brachial plexus. Particularly that ulnar nerve distribution seems to be vulnerable with that metastases. When we're looking at any patient, we should really be assessing the entire quadrant. So we need to not only look cervical, but look head and neck. What you'll see in the patient, they'll have the ulnar nerve atrophy. They will have, a typical presentation, but if you look higher up, if it is Pancoast syndrome, you're also going to see Horner syndrome presentation, where they have ptosis with the drooping of the eye. They have hemianhidrosis, which means they lose sweating on that same side. So one side of their face will perspire, the other side of the face will not. They're going to present with pupillary constriction on that same side. And then if we look at the eye, it's more sunken in. So be aware that this could be a medical condition that requires more than we can provide, and referral back to the physician, of course, without panicking the patient. Compressive neuropathy management for our patients, regardless of where the compression is occurring, there are similar trends in the management with using daytime or nighttime splinting to avoid any positions that will place excessive pressure on those nerves. For carpal tunnel syndrome, we're going to be avoiding excessive flexion. For Guyon's canal, we're going to be avoiding that excessive wrist extension with weight bearing. And then for cubital tunnel, elbow flexion tends to be our greatest concern. As we look at patient education with activity and ergonomic and workplace assessment to try and avoid those precipitating factors to compression, and then based on the mechanism of injury, we'll make suggestions for that patient to have more appropriate alignment, avoiding those compromising positions. In some instances, if conservative management is not successful or if it's a space-occupying lesion, then decompression surgery would be indicated. As we look at pathologies that are going to involve tendons, de Quervain's tenosynovitis is the first one that we'll discuss. We are looking here on that radial side of the hand near that wrist and thumb. Specifically, we're looking at the tendons coming down of the abductor pollicis longus and the extensor pollicis brevis as they come down to innervate the hand. These are covered by a retinaculum. There tends to be a little kind of padding located in between those two specific tendons, a septum that separates them. And when individuals perform repetitive motions of radial deviation, this is going to create stress across those tendons. Sorry, I said radial. When they perform excessive ulnar deviation, it's going to cause repetitive motion of those tendons and stress of them. There are several different ways that this can occur. Grasping motions of the thumb, someone who is hammering, individuals who are postpartum, those moms holding their baby so often, like in the image here, we can envision her thumb in this position from her hand, and that excessive force of the baby and those motions to hold lead to the development of this pathology. If you're working in women's health, this might be something to educate on prenatally, so there aren't pathology postnatally. It tends to take about 2 to 3 months postpartum to develop. Some treatment interventions in terms of activity modification would be using more tummy time, use electric openers instead of the excessive twisting and motions, look at the position of feeding for the baby to avoid this. When you think of de Quervain's tenosynovitis in terms of excessive movements of the thumb, originally when video games first came out, it was called gamer's thumb. Then when the BlackBerry came out, which was the ancient ancestor of our smartphones, it was BlackBerry thumb. Then it moved on to texting thumb, and now we're seeing it as mother's thumb. Either way, it's those excessive thumb motions, particularly with ulnar deviation. So it could be work positions also that are occurring. what's happening is they again are realizing that it's more of a tendinopathy, not an inflammatory type of condition. When we look at the tendons passing through this covered tunnel, they're noticing that the repetitive friction that occurs from the excessive motion puts a lot of shear force across those tendons. And not only do the tendons start to thicken, but the retinaculum across the top of it also begins to thicken. So we have all this increased density creating a narrower tunnel and repetitive movement that's occurring. Histological examination, when they actually went in and looked at individuals who had surgery for this condition, they found that the thickening of the tendon was up to 5 times normal, so really encroaching in that space, and that there was actually a degeneration of the tendons and the surrounding tissue, that it became more of a gelatinous mucoid type of tissue on histological examination. There was really disorganized cellular matrix, and it didn't really heal well. So when you combine all this, we have impaired gliding, and the perpetuated use kind of adds to this pathology. That's really more consistent with degeneration as opposed to an inflammatory condition. The clinical presentation that we're going to see is pain in that dorsolateral border of the radius that's going to be exacerbated by resisted thumb extension when the patient attempts to utilize those muscles. The Finkelstein's test will be positive, where you place the thumb in the palm and then ask the individual to ulnarly deviate. That is going to replicate that pain pattern. Because we may see some slow progress with the patients and we need to quantify the discomfort that they are experiencing, one scale that I found in the research had you palpate over the region where they would be tender. A 0 would mean there's no tenderness that's noted. If we palpate the individual and they are complaining, maybe just making like a facial change, like a grimace, that it's uncomfortable, that would be a 1. If they make a grimace and they kind of flinch a little bit, that would be a 2. And then when you palpate, if they actually withdraw, that would be a 3. So that might be another way of grading to see improvements that may be small also. Looking at a 2015 systematic review for some treatment options for de Quervain's, splinting seems to be helpful for individuals. The thumb spica that keeps the thumb out in some abduction as well as extension. Interestingly, kinesiotaping was also found to be beneficial, as well as phonophoresis for individuals with this condition. Trigger finger and trigger thumb. We are looking now at tendons in more the palm of the hand. We tend to see that trigger finger, when an individual, we ask them to close their hand. If that tendon starts to catch, so the individual may be able to close their hand, but when they go to open it, it may not open smoothly. It may pop when they try to extend it, or some patients may actually have to physically move into that extension. More commonly in the middle and ring fingers for the patient. And then in pediatrics, it also tends to present itself in the thumb. The pediatric etiology, they think, is a mismatch between the thickness of the tendon and the sheath and the pulley that it has to go through. There's really no specific agreement in adults as to what causes this pathology. Some evidence says that maybe there is some type of overuse pathology with excessive compressive force in the palm of the hand, like using gardening shears or big welding equipment with those high forces generated. Others say that it's just an overuse type of pathology, and in many cases it just seems to be idiopathic in nature. Either way, what we do see in this condition is a compromise to the tendon related to the flexor pulley system. When we look at the flexor pulley system of the finger, we're going to take a look. We have all these tendons coming down into our fingers. And when we consider all of these multiple tendons coming down into the fingers, something has to stop them from bowstringing or falling away to maintain their mechanical advantage. And the easiest way to think of this is if you go fishing in the top image here. You have these little guide rings along the fishing pole that are going to stop the fishing line from falling away. Well, the same thing when we look down into our fingers. We're going to have a mechanism that helps keep these tendons in place. So if we look at the image here, approximately around each joint, we're going to have a little pulley called annular pulley that goes around to hold that tendon in place. And then if you think of those as rings, well, what's stopping those rings from sliding right off? Then additionally, we're going to have, like in the knee, cruciates that are going to crisscross to help hold that in place. The hand is very complicated in structure, and I'm oversimplifying it, but I think it gives us this image that these annular pulleys are important to keep the tendons and to allow them to glide. That also creates a confined space that these tendons need to glide in. So when pathology results, we need to look at the relationship. And I'm just going to use my little chopstick here to give us a visual. Whatever the reason, the individual has a pathology where my chopstick is my tendon, my wrapper is our sheath here. When we look at when someone flexes down, the tendon and the sheath should flex down together. And then when we extend back up, they should extend back up together. What happens in this pathology is when the person flexes down, you see this excessive sheath, it's going to bunch up underneath the pulley. So when the patient goes to extend and they try to extend it, all this extra bunched up sheath can't get past that annular ring to go back up. Now, if it's not too progressed, maybe the individual can still extend. But as the pathology progresses, not only does that sheath become restricted, but the ring itself becomes irritated and hypertrophied. Now we have a smaller space and it can't get through. And that's why the triggering is the popping up. When they can flick that bunch of sheath back out, that will create that pop and that snap, but now that's creating more inflammation in the area, perpetuating this process, and eventually it may reach the point where the individual cannot volitionally open and they need to manually do so. When we palpate the hand of the patient around that first annular ring at the metacarpophalangeal joint, you are going to be able to feel that nodule of bunched up tendon. And the way that you can grade this to see if the condition is progressing or improving is you ask the patient to open and close their hand 10 times, and you look at the quality of the movement, and you count every time that it catches for them. If they fully lock down and they can't open it back up, then that is going to automatically give them a 10. Looking at management, what has come up in the research studies that I looked at, comparing Ceriax massage, instrument-assisted soft tissue massage, they really didn't find one intervention that was better than another. They also considered tendon gliding. Some support was found for the use of like a little O-ring that would only allow the patient to flex down a certain amount to allow performance of functional tasks, but not flex down so far to the point where that sheath became bunched up on the wrong side of the pulley that they couldn't get it back open. If conservative managements are not successful for the patient, then surgical intervention may be necessary. Dupuytren's disease is our next condition. Now we're moving on to the fascia of the hand. When we look at the role of the fascia in the hand, this is going to provide a layer of thick tissue that is going to have communications coming up into the skin. So when we go to open that jar or create force across our hand, we don't just have all our layers of tissue sliding on each other. And certain individuals, they tend to have a genetic predisposition to an abnormality of this fascia. They've recognized this by looking at twin studies, and they've actually found an 80% familial history with Dupuytren's disease. It's a genetic condition where that palmar aponeurosis, it does not form normal collagen tissue. Some type of triggering event usually causes it to become active. Some research says that it is if someone has a surgical intervention or excessive activity with compression. Something that changes the microcirculation in the area seems to trigger this process where the individual first is going to form these immature fibroblast cells that the growth factors they're noticing tend to produce fibroblasts that lead to the development of more type 3 collagen as opposed to type 1 collagen. It's not as elastic. Then as the individual continues to perform the activities of their hands, not only do they just have these kind of whorled nodules, we know that tissues align themselves along the lines of stress pull. So as the individual continues using their hand, it starts to create these cords that follow the path of the tendon, and then ultimately they can continue to contract down and actually shorten, lead to contracture of the cord, and then the adjacent tendon is also going to contract down. As we understand this process, then we can recognize that's the disease process. Ultimately, the individual presenting with the contracture, Dupuytren's contracture, is the symptom of the disease of the abnormal tissue formation. Early on in this top image, we tend to see in this square that I'm creating the puckering of the tissues when the nodules form. And then in the bottom right, we can start to see the cords forming. So those are the abnormal collagen tissue that create these rigid cords. The tendons for that patient would be separate from that. So when you palpate, you can distinguish that difference for them. In terms of management, the challenge becomes, because this is an abnormality of tissue, that it may return for the patient. So conservative management can be attempted for some patients. What they're finding is that once the patient reaches a point of a 30-degree MCP contracture, at that point, that hand is not really functional for use. So surgical and other intervention may be necessary at that point. Corticosteroids seem to soften a little bit to be helpful, but surgical intervention may be necessary. Looking at that difference between trigger finger and Dupuytren's disease, trigger finger, we're going to actually feel that nodule because it's the sheath that's bunching up beneath that pulley, versus Dupuytren's is a disease of malformation of the fascia and the palmar aponeurosis that leads to these cords and bands that ultimately contract the hand down. Compartment syndrome is our next pathology that is going to involve the fascia of the distal upper extremity. We have these different fascial compartments that divide the forearm into groups of muscles. We have our extensors of our wrist and fingers. Then we are going to have our flexor compartment, and then our final compartment, we're going to have our brachioradialis and our extensor carpi radialis longus and brevis. Mixed within these compartments, we have our rigid bone deep inside, and then the fascial compartments to keep everything aligned. Within there, we have our lymphatics, our blood vessels, our nerves. There are many different conditions that can alter the volume in these regions that can then place pressure on the circulation and the nerves. Several acute Examples would be someone who has a supracondylar fracture of the humerus or a proximal radial fracture can create swelling in response to that fracture that can build up. Individuals who have IVs in the area that become infiltrated, someone who maybe used IV drugs and became unconscious where they left that tourniquet on. It can lead to the buildup of fluid and compression in the area, as well as circumferential burns. Bites from different animals or snakes can inject venom into the area, create an inflammatory process that creates inflammation. And then another way we can look at those are more the acute. There's also a chronic development of compartment syndrome. This might be part of your differential diagnosis for our distal upper extremity patients, an overuse syndrome. When someone performs activities that require a lot of gripping movements, so riding a motorcycle, kayaking, baseball pitchers even, I read a study or case study of a woman who randomly one day did 100 push-ups, and she had never done that before. And she developed compartment syndrome because there was so much metabolic activity and fluid buildup in the area. My first thought was, how do you go from 0 to 100 on push-ups? That was a whole other thought. It did bring up the point, though, that overuse of the muscles can create, they call it rower's arm sometimes, can create a compartment syndrome. Regardless of the mechanism, whether it's a trauma or an overuse situation, the clinical presentation of what hemodynamically happens is going to be similar. Particularly in pediatric cases, you want to monitor closely when someone seems to have had a mild fracture for the development of compartment syndrome. They're saying that many of the cases that are clinically diagnosed, up to 50% of them are in pediatrics. This child, we can see, has so much fluid developing that it's actually blistering out. What initially happens is we have swelling in the region of the compartment from whatever the mechanism is. We have an increase in fluid volume. What happens is, as that fluid volume increases, it's going to limit the venous outflow. When we have decreased venous outflow, we're going to have a buildup of those metabolic wastes. We're not having any relief of the excess fluid from the area, and that's going to result in an increase in the interstitial pressure. We have this increase in the interstitial pressure, and it's expanded as much as the soft tissue is going to allow. At some point, as that pressure continues to build, because we don't have venous outflow and we don't have management of whatever's causing the excess volume, now we have an altered gradient where the arterial flow can't even get in. So we have this altered gradient and we have decreased arterial inflow, decreased oxygen, decreased nutrients, and we're in a situation of ischemia where there can be necrosis and significant damage to the tissues in that extremity. This is going to become a medical emergency, because if the pressure is not managed and restored to the area, we're having not only ischemia, we're having neuronal compression and the development of Volkmann's contracture, where we have liquefaction and necrosis of those flexor muscles can occur. This is a patient where on the top image, we see significant pallor, and they were able to catch it early enough to relieve it, and they have restored motion and circulation. Pain is going to be a primary symptom, pallor, decrease in muscle strength, and poikilothermia. To highlight this, you're actually going to notice that limb will be colder. And when we think of vascular issues, we tend to think of warmth. The reason the limb is colder is because we don't have the arterial flow coming in of that warm oxygenated blood. This is what we want to monitor this patient for, and it is a situation where the patient is going to need some rapid intervention, often surgical, to alleviate that pressure. Looking at bony involvement of the wrist and hand osteoarthritis is not as common in the research as of the hip and the knee. There was an interesting report in the International Journal of Molecular Science where they looked at osteoarthritis in the 21st century. What they proposed got me thinking of our opportunities if you're working with pediatric obesity or young adults even, if you're just doing general community outreach and education, and then when you have younger individuals coming in with wrist and hand pathology, to consider that it could be osteoarthritis starting to develop. Here's what they proposed, that kids nowadays, they have a digital device in their hand at such a young age. I am constantly amazed at how many 5-year-olds can still teach me many things about how to use my smartphone. So they're digital natives, and they're performing all these repetitive movements with their hands from such a young age. They're young developing joints. That articular cartilage, we know, doesn't have a great vascular supply. Their joints are not strong yet. Their ligamentous structure is not strong yet, so they're more vulnerable to dislocation and subluxation with excessive forces that are abnormal and continuous placed upon them, which may lead to different weakness and awkward postures. And ultimately, this can lead to the development of osteoarthritis and predispose them earlier to its development. Combine that with the challenges with young adult and pediatric obesity, we're looking at increased risk of that development of osteoarthritis. So opportunities here is what I say. As we look at individuals in general presenting with osteoarthritis, they're going to have hand pain, stiffness, decreased range of motion, and difficulty with different functional tasks. The bony deformities that are common, we know our Hebernins and Bouchard nodes, those small bony elevations that we're seeing. When you look at a patient that may present, as on the right here, with a digital mucus cyst, it may look just like maybe a blister or some type of wart. It's kind of bluish, red, shiny, could be just like right along the edge of the nail bed even. What they're finding is that this is a communication coming out from that deteriorating synovial joint, and it might be an indicator of that osteoarthritis. Carpometacarpal osteoarthritis is common of the thumb, and a grind test can be utilized in order to assess for that. When patients have that kind of non-specific pain in this region here, we do want to distinguish carpometacarpal arthritis from that de Quervain's tenosynovitis that we discussed. Management of osteoarthritis for the wrist and hands, looking at a 2017 Cochrane review. It was a meta-analysis. They pulled all the research. I was very excited when I found it, only to find out their conclusion was that, in general, there was low-quality evidence for the wrist and hand, unlike the hip and knee where all the research is set. I looked to the European League Against Rheumatism that puts out osteoarthritis guidelines, and I was able to find their suggestion that conservative pharmacologic management, we now see that there are topical anti-inflammatories that might be providing some release for individuals, a focus on patient education, exercise. The trend is to lean towards symptom control more so at this point, not so much joint protection, but educating patients on what is causing their symptoms and the deterioration, ergonomic assessment, activity modification, adaptive equipment, so that long term they become armed with the information to make better decisions and perform better to help offset some of the deterioration of their joints. They are finding that surgery might be indicated for some individuals if that carpometacarpal joint becomes so severely compromised that the hand becomes non-functional. Rheumatoid arthritis is a systemic autoimmune condition. The individual has multi-system involvement as the disease is going to progress. When we look specifically at the hands for the individual, the small joints tend to be more impacted with that morning stiffness. The deterioration of the joints leads to easier subluxation and decreased functional ability to use the extremity. When we're treating patients with arthritis, rheumatoid of the hands, they're going to go through periods of exacerbation and remission, and it's helpful for us to know that pattern and for the patient to know also. The DAS28, the disease activity score, is what's utilized not only if you're reading the research to see what medications or treatment interventions are best, that's the outcome measure that they use. Also helpful when the physician performs it if we know the patient's going for a visit, if we can find out what their score is. The physician's going to utilize this tool, and it's a combination of information that's utilized. The lab value of the erythrocyte sedimentation rate, the palpation of the 28 tender points and swollen joint count to see the extent of the disease. It also has a global assessment of health component because it is a systemic condition. If an individual is below a 2.6 score, they're in remission. If they are over a 5.1, that means they're in a state of high disease activity. This might help let us know in terms of our intervention programs if they're not as successful and then they're at a high disease state. Maybe we want to lean more towards patient education and activity modification versus someone that's at a lower state. We might have better opportunities with more activity-based interventions. Looking at it from that slightly different perspective, when we have individuals with the rheumatoid arthritis of the hands, we are focusing on function. And when we're trying to improve that, it's not just range of motion and strength that we're trying to gain. We want to look at all the pieces that come in to their ultimate function. With the many different systems involved, we want to maybe consider adding a vision assessment to see if that individual needs a referral. If they tend to have more dry eyes, corneal involvement, the vision restriction might be impairing, combined with the decreased function of the hands, their functional activity. Also, if they have a peripheral neuropathy, that can be contributing to that fine motor decrease and sensory changes, so they might need more intervention in that sense. Lung fibrosis is a concern, which is going to lead to decreased endurance, not only cardiovascular, but potentially muscle endurance. So pacing activities might be necessary and awareness of this for the patient. And maybe there's an opportunity for some endurance training that can translate into better hand function. We also have hygiene concerns. Are we addressing that? Giving appropriate equipment? Can they get to the bathroom appropriately and use the fine motor appropriately? Because when there is renal involvement, they need to have better hygiene also. The changes that we're going to see specifically in the joints of the hand are going to be related to the subluxation that occurs as we have deterioration of those joints of the hand. Ulnar drift in the far left image can occur, where we have subluxation of the digits in an ulnar direction. We're going to want to limit twisting activities and other activities that will further progress that. We can have thumb involvement as well as our boutonniere type deformities and swan neck. When an individual like on the right has that boutonniere deformity, when you see that, you don't want to just be thinking, oh, I need to stretch that out. Those flexors are tight. Oversimplifying what's happening, we need to recognize that as there's deterioration of the joints in a patient with rheumatoid arthritis, it's not just the joint surfaces, it's the synovium. It becomes deterioration of the tendons and the other adjacent tissues. So when the patient has that deterioration of the joint, they may have a shift of the lateral bands of that extensor hood mechanism. The finger extensor tendon can actually become ruptured. So you may not be able to gain range of motion, and even if you do, they may not be able to initiate voluntary finger extension. It might be at some point where we just need to look towards adaptive equipment. Management for rheumatoid arthritis is going to be multifaceted with medication to control the autoimmune component, and then our specific interventions of patient education, joint protection, and energy conservation along with equipment. Looking at the different research that's out there, it was noted that wrist splinting is beneficial to improve dexterity and grip for patients, that stabilization allowed for better use of the joints that they did have control over. Compression gloves were something kind of like a fad, I guess, that was out there for a while. The thought was that the compressive force helped control the swelling and the pain for the patient. It altered the lymphatic flow. Research isn't really supporting that those had any particular benefit for the patient. On a plus side for us, research is supporting that therapeutic exercise can help improve function for the patient. It doesn't necessarily decrease their pain, but it may allow them to be more functional. They also noted improved disease activity scores in individuals who were performing exercise. Joint protection for arthritis seems to be more beneficial with individuals who present with rheumatoid arthritis. The research looks at some examples I have here of how to protect the joints, the do's and the don'ts. When we're educating our patients, do we just go over this one time or hand it to them, show them a couple of pictures, and anticipate that they're going to get that carryover? Looking at how that process occurs and what actually is beneficial for patients with arthritis, there's a lot of non-specificity in the research. The couple of studies that I found looking at how long do you have to educate a patient, how much follow-up do they need, they found that somewhere between 1.5 to 3.25 hours of training, like very specific on joint protection, spread out over more than one session, did seem to have a carryover for the patients where they were better armed with the information to make good decisions, to improve their function, decrease their pain, to become more problem solvers when they have this arthritis versus more of a do's and don'ts perspective. As we look at fractures that can occur of this distal upper extremity, the radius is one of the more commonly fractured bones. Fouche injury, that fall on the outstretched hand, is our common mechanism resulting in a Colles fracture, where we are going to see more of that dorsal displacement of the hand. Based on the wrist position, when the individual falls, they may sustain on the right a Smith's fracture. That's sometimes called our dinner fork fracture because of the curve, where we have the palmar displacement of the distal bones. Generally speaking, when we look at distal radius fractures, high energy traumatic type fractures of this bone tend to happen more in the older active population or youth, and then it tends to be more a low energy type of fragility fracture in our osteoporotic and our older patients. When there is fracture of the radius, we do want to know if it is, like on the right-hand side here, an intra-articular fracture that is going to heal differently and down the road have greater risk of other complications versus something that's extra-articular. One way we can gain information on this is through looking at the reports. Oftentimes, our patients just come to us with the diagnosis, an ORIF of the radius. Well, maybe you want to know a little bit more than that. There are a couple of different classifications that are utilized. The AO classification, back in 1987, this was the Swiss surgeons version that I can't pronounce. The OAT version, the Orthopedic Trauma Association classification system, came out around 1996. Finally, in 2006, they realized, can we please have one classification to make it easier and universal for everyone? And that's the classification we're going to discuss today. The way it's set up is that every bone has a number to it. And the numbering system lets you know a lot of information about the fracture. Looking specifically at the distal radius fracture, the number 2 tells us that it's a long bone. The R lets us know that it's the radius. 3 lets us know that it's that distal segment. And then we're going to have A, B, and C, which are going to tell us more information specifically about that fracture. A fracture that is an A fracture might look something like this on the left-hand side here, where it's an extra-articular fracture of that radius. A B fracture is going to go through the articular surface. However, the segments are going to remain aligned. And then a 3 is going to be an intra-articular fracture where there's actually disruption of that articular surface and separation. So you can imagine different surgical procedures might be necessary, and what the physician permits post-surgically intensive mobility may be different also. Some other fractions you might not encounter as commonly but should be aware of are the Galeazzi and Montaguy fractures. These are fractures of the forearm, and GRIMACE is our acronym to help us remember us. The GRI of GRIMACE means that it's a Galeazzi fracture. The radius inferior third is going to be fractured. So, and the image up here, we're going to see, and I'll show you on my model here, that somewhere on this distal third of the radius is where we will see our fracture of the bone. And then because that radial fracture has occurred, when there's shifting of the segments, it's going to affect this ulnar positioning. And we're going to see in the image here, ulnar dislocation. This patient then, because of that radial fracture location, they're at risk for that anterior interosseous nerve syndrome. Pronation, supination tend to be more compromised. And then because of that ulnar involvement, the triangular fibrocartilage complex that we'll discuss can also be involved. So not only do you have the radius fracture that you have to address, don't forget that ulnar component. Next is our Montaguy fracture. This of GRIMACE is our MUS. The Montaguy fracture is going to be a fracture of the superior portion of the ulna. This is a patient who might be in a pronated elbow flexed type of position. And when we're in this position, if there's a trauma that occurs in this direction, right to that ulna, they're likely to sustain a more proximal fracture, like on the left hand here of that superior location. And then that force is transmitted through to that radial head here, and we're going to see a subluxation of that radial head also. This patient then, because it's more proximal at the elbow, we have more concerns about elbow range of motion, posterior interosseous nerve syndrome, and that may even happen a long time down the road. Maybe the fracture is realigned, but that radial head really hasn't been fully addressed, and there's slow irritation of that nerve. Based on these fractures, you're not only going to think of your typical range of motion, you're going to be aware of the other joints that will be involved to be comprehensive in your rehab. Pediatric fractures are going to look a little bit different. Pediatric fractures, because the bone tends to be softer for the patient, it's not fully ossified. A buccal fracture is going to occur where one side of the bone is going to compress and the other side is going to bend. So we have a compression here and a bend on that side. Green stick fracture, we're going to see a little splintering off of the bone. We can have a complete fracture across the shaft, and then we can also have those growth plate type of fractures. As we look at the Salter-Harris classification of those growth plate fractures, I will be completely honest, this is a chicken bone. I couldn't find a human bone growth plate that was not copyrighted. What we see here, as we look at the growth plate, we have different zones within it. There's a resting zone, a proliferating zone, the section where there's maturation occurring, and then ossification. It's a very small area, but depending on where the trauma is going to occur, it's going to impact potential future growth of that bone in the child. Unfortunately, what they find in most growth plate fractures where they're occurring do tend to occur more in that maturing and ossifying region of the bone. Our abbreviation to remember the different classifications, type 1 through 5 are what tends to be utilized a little bit more now, and Salter, the name, helps us remember the location of the fractures. Our S type 1 is going to be a straight through fracture, complete disruption of that growth plate. Type 2 will be above the growth plate, and it's going to take a little wedge out of the bone, kind of like a crack off of that bone shaft. L is below, and it's going to take off that whole wedge of the bone. Our type 4 is our TE of Salter, meaning through everything. So it's more of a diagonal type of fracture, and now we're looking intra-articular also. And then we have our for crush of Salter. So depending on where the fracture is, the concern is whether or not that bone will continue to grow for the child. Fracture management for adults and pediatric cases has many different options of where to focus on that, whether they're utilizing some type of external fixator mechanism, internal fixation, or casting. Some research that I found looking at trends in management, review of over 3,000 pediatric cases. They really found variance in how the different fractures were managed, and they all did have improvements in function. The one trend that did seem to emerge is more of a shift, moving away from casts to more splinting for the buckle type of fractures to allow for more earlier movement to retain some of that mobility of those carpal joints. Complications we're going to monitor our patients for post-fracture are lack of healing, osteomyelitis, any of the neuropathy development and carpal tunnel syndrome, compartment syndrome, and chronic regional pain syndrome. The two that you may not be as familiar with are ulnar impaction syndrome and triangular fibrocartilage complex injury. There can be additional regions involved when we have a fracture in this distal extremity. In order to understand this, we need to take a little bit closer look at the ulnar articulation at the wrist. When we think of the wrist, we think of that radius articulation with the scaphoid and the lunate as really important, which it is. However, we also have that ulna. And when we're holding different loads, there's a great distraction force that's placed across that joint. We're putting compressive loads. There needs to be cushioning. And remember, this really isn't a true joint. It doesn't have its own structure. This is a scan and staining looking at the ulnar complex. When we look, let's orient ourselves. This is the edge of our ulna, and this is our triquetrum here. When we look in the middle of this, we have this triangular fibrocartilage. It almost looks like a sling in the middle here. And that is a little disc that's located in order to provide some compressive force on that ulnar side of the wrist. Similar to our articular discs or our meniscus in our knee, it has a little vascular supply on the periphery, but not so much centrally. So it really has a challenge for healing that it's really 80% avascular. And it provides a critical role in absorbing all these different forces placed across the wrist. That is just one component of this whole triangular fibrocartilage complex along that ulnar side of the wrist. What we have in this region, in addition to that triangular fibrocartilage in here, we need to have stabilization between our distal radius and our ulnar with ligamentous support. Vertically, we are going to have a ulnar collateral ligament providing stability in that area. And then there's also a thin meniscus that runs like in tandem there with that ligament. This whole complex together plays a role in not only stabilizing that distal radial-ulnar joint, every time we pronate, that ulna needs to move a little bit inferiorly. So it needs to have space to do that and that disc for absorption. So there needs to be stabilization there. Also, we need to distribute the loads across that ulna when we're applying different compressive forces. And this complex allows all of that to happen sufficiently. component to this is ulnar variance. We know that in the lower extremity, if we have a leg length discrepancy, it's going to change our step and our stride and our shock absorption that somewhere else in the chain needs to be absorbed. Same consideration comes into play when we look at ulnar variance. When we look at our radius and our ulna, and this alignment here, there needs to be that little bit of distance on the ulna side for that translation during pronation. When they measure this on X-ray, there should only be about a 1 millimeter difference here between the distal end of the radius and that distal end of the ulna. What we're talking about here, that brand new fresh crayon, I always can mentally remember childhood smelling that brand new box, is about 2 millimeters across the top. Nice sharp pencil, brand new point, is about 1 millimeter. So we're talking about a really small difference here. If someone has a positive variance, that means that that ulna is extending beyond the radius. That means that ulna is going to be impacting more on those carpals. If someone has a negative variance, that means the ulna is going to be shorter, and now we may have some instability of the carpals and that wrist joint, all of which can lead to different pathology. One of which is ulnar impaction syndrome. You might have heard this referred to as ulnar abutment syndrome or ulnar carpal abutment syndrome. What we're seeing, if we look at the scan on, I think we can see it better on the right. If we look at the distal end of the radius and the distal end of the ulna, we can see that the ulna projects more. And because of that, it's articulating more closely here with that lunate instead of having that space here between the triquetrum. Like on the left, we should have more space in here. What happens in this pathology is excessive compression. Why this happens, it could be for several reasons. One might be someone who had that pediatric growth plate fracture, where on the left here there was a fracture. Now this radius, it's not growing. It's halted, but the ulna is going to continue to grow. It's sometimes seen in gymnasts where they have excessive compressive force over that radius during the critical growth years, where it arrests that development a little bit of radial length, but the ulna doesn't have as much force on it, so it can continue to grow. If someone has that radial head fracture that's migrating that radius shorter, this can all lead to that ulnar impaction syndrome. What happens when we look down at the ulnar surfaces of the joint, when we have that positive variance where the ulna is longer than the radius, we have excessive loading on those ulnar carpals. So that triangular fibrocartilage disc that should really be sitting here like a hammock, well, now we have our ulna compressing into it, stretching it out. And remember, it's not very vascular. It's going to overstretch it. Every time we pronate and flex, which is many of our functional activities, you're pushing that further, leading to degeneration, and ultimately it can also lead to chondromalacia. If we look at the scans here, we can see significant deterioration on the left top image of that lunate because it shifts where the weight's applied. That lunate takes more stress. And in the bottom left, we can see on this scan that there's actually sclerosis. It's much brighter in that image where it's deteriorating. The way someone will present clinically if this is happening, they're going to complain about that ulnar-sided wrist pain, particularly when they do those pronation and gripping type activities, or where they're doing any activity where they're weight bearing through their wrist. Sit to stand may be the first thing that you think of. We also weight bear on that ulnar side of our wrist when we're pushing a door closed, pushing a drawer closed. Lots of different activities would cause that pain for the individual. Decreased range of motion into that pronation and wrist movements, as well as pain in that ulnar region. Conservative management, there was a patent that I read that's pending on a splint that kind of shifts up. It has like a little pad in the pisiform region to try and shift the carpal mechanics to create a space. Corticosteroids might be beneficial, just activity modification to take the stress off the joint. But if there is significant damage to that complex, surgical management may be necessary in order to alleviate the symptoms for the patient and halt the degeneration that's occurring. Moving over to the medial side of our hand, that scaphoid is a very critical bone in our hands. Looking at our scaphoid that articulates with our radius in order to create that wrist joint along with the lunate. Scaphoid is kind of shaped like a little boat. It actually comes from the Greek scaphos, meaning boat. As we look at that, because of the little curve of the scaphoid, it can fracture in a couple of different locations. We can have a distal pole fracture like on the left, a proximal pole fracture on the right, and then it also has a waist. It can fracture through the middle. The most common mechanism of injury for the scaphoid is going to be a Fuchs injury, which is a fall on an outstretched hand. Depending on the position of the wrist, usually if there's hyperextension and ulnar deviation, it exposes that scaphoid. And then when there's the compressive force, just above the line that I draw here on the right, we can see that fracture of the scaphoid. It doesn't only occur with a fall. Other mechanisms of injury might be someone that has a kickback injury if they're using a tool like a drill, or it's drilling in and it jams when it goes to turn, but it doesn't, and it kind of gives force back in. It tends to hit right on the scaphoid and can create a fracture of it. The clinical presentation that we're going to see is important to note when you have those patients coming in with those generic diagnoses of wrist sprain. Earlier on, remember we said that a lot of times carpal fractures are not caught on initial x-rays. In our minds, we're always going to be mindful of that is it a soft tissue injury or a potentially undiagnosed fracture? Doesn't mean anything was done wrong, it just means it may not have been evidenced as easily. The clinical presentation that you're going to look for, if it is a scaphoid fracture, is where there is some type of history of trauma and the individual is continuing to have functional deficits and pain and tenderness in this anatomical snuff box region, where they're just not responsive to interventions that should be showing improvement, and or they're deteriorating in their functional status and having increase in their pain. When we look at this anatomical snuff box region, that is going to be located between the tendons of our extensor pollicis longus, our abductor pollicis longus, and our extensor pollicis brevis. Between those, here we go, tendons, there we go, in this region. If you have the patient relax and palpate right in the bottom of that snuff box, that's where the scaphoid is located, and it may be tender, maybe a little swollen. That's very close to the region for our de Quervain's tenosynovitis. We'll be mindful to differentially diagnose between those different pathologies. When the individual is working on pinching and grasping type injuries, it increases the stress across that scaphoid and is likely to increase their pain, and they'll test out with a decreased grip strength. The way that oftentimes this is managed when the patient has a generic wrist sprain is where they'll be splinted for some type of short-term 2 to 3 weeks and go through rehab. We're going to be monitoring them for this scaphoid fracture. The big concern with the scaphoid fracture is avascular necrosis that the individual is at risk for. When the individual's in that thumb spica cast, once the fracture has been identified, it's going to keep them aligned to allow stability of the fracture. If it is more of a proximal pole fracture, surgical intervention is usually required. When we look at just in this image here, we're kind of like popping that scaphoid out and looking at it by itself. We think of circulation that it's usually better proximally than distally when we look at vascular conditions. It's a little different for the scaphoid. It has a unique vascular supply that places it at risk for this avascular necrosis. When we have the dorsal radial artery coming in, it takes a U-turn, and it's going to supply approximately, this region of the scaphoid, because it takes that U-turn as it comes around, about 70 to 80%. Then we're going to have another artery, make a different color here. We're going to have our palmar radial artery that comes down, takes its U-turn, and that's going to supply that distal pole. Again, we're looking at about, 20%. So that is going to leave this proximal pole here without a really good vascular supply. And if that's where the fracture is, the patient is at risk for a delayed union, non-union, or avascular necrosis. It's a significant concern. So we're going to see when there is a fracture of the scaphoid, a very slow progression of the patient over a course of 6 months to allow healing of it because of this tenuous supply. When we're able to start mobility with the patient, we're going to hold off on holding heavy objects or lifting heavy objects. We're keeping it below 1 pound. We're going to be aware of anything with vibration places excess stress, not only across the fracture site, but to that microcirculation in the area. That patient may have the cast on and be like, oh, I'm good. I can use my electric toothbrush, use my electric razor because I'm stabilized. But that vibration force is still going through that can be disruptive. Also consider the patient if they're engaging in any activities where they may lose their balance and have to catch themselves, or if they're just using that hand just to balance. That can be putting force through this joint. So patient education is really important for patients that are healing from our scaphoid fractures because of this very tenuous blood supply. As we look at the alignment of the other carpal bones, we're going to look a little more closely at what's called the carpal arc. The greater carpal arc is looking at the positioning of all of the carpal bones sitting around the lunate. So we have all the carpal bones and how they align. The lesser arc is looking specifically at just those ligamentous support structures around this lunate itself. And the lunate is important because unlike other carpal bones, it's wider on the palmar surface, and it makes it more likely to slip out into that carpal tunnel region to sublux. And then also that the lunate doesn't have other bony attachments on it, that it really kind of relies on that architecture and the fact that it's just balanced just right and articulating just right to stay in place and perform its functions. Makes it vulnerable to injury. And the pathology that we see resulting is perilunate instability, peri meaning around the lunate instability of the other carpals. This can happen a couple of different ways, and there can be concurrent fractures of the lunate along with these injuries. It's usually a very high impact trauma type of injury. I looked at studies from the United States, Turkey, France, and all of the research says that this is a devastating injury of the hand, that when that architecture is disrupted around that lunate and those carpals shift, that even patients who have early surgery and good rehab do not obtain full function of their hands. So this has to be recognized and addressed early. And we need to be very cautious and comprehensive in our rehab also. The greater arc injuries, this is going to occur when we have a pathology where there's been trauma to the region and we have dislocation across this greater arc, that we actually have shifting of all the other carpals off of that lunate, but the lunate is going to stay with that radius in order to give wrist stability. The other injury, the lesser arc injury, is going to be the opposite. This is going to be when that lunate itself is going to sublux out into that carpal tunnel, and then that's going to shift all of those other carpal bones. The patient is going to present with general swelling. They'll have dorsal pain of the wrist, particularly if there's a concurrent fracture of that lunate. They might present with median nerve symptoms like a carpal tunnel if that lunate has subluxed out. It tends to be more of a diffuse pain that the patient has, that when we look at where to palpate for that lunate, we're going to find that Lister's tubercle goes slightly to the ulnar side and then inferior, and you should be landing about on that lunate for your palpation. When they have closed reduction, the concern is the vascular supply has to be intact. Oftentimes, open surgical procedures is necessary because the ligaments also have to be managed. Like the scaphoid, there's a risk of avascular necrosis of the lunate. It's called Steinbach's disease. This is an example of a patient we can see here where the lunate should be. We're just seeing a black area on the scan, and this is the lunate. When they actually took it out, it had deteriorated so significantly. It has a very tenuous blood supply also. It's at greater risk of deterioration when it does shift out of place. Then it shifts the mechanics of all the other carpal bones, leading to further deterioration, particularly of grip strength for the individual. We see on that scan that uneven density and the collapse in that wrist region. We can imagine for the patient how painful and uncomfortable that would be. In early stages, they might be able to immobilize it and allow healing to occur. If not, then surgical intervention may be necessary for the patient. Over time, the concern is the development of arthritis in all of the adjacent carpals as well as the radius. Triangular fibrocartilage complex tear. We're looking at pathology on this ulnar side of the wrist, of that whole stabilizing complex that's so important to our wrist movements. There are two general types of damage to these structures. The first type is going to be our acute trauma. I have been water skiing since I was a kid. And the first thing you learn is to let go of that rope. Not because you don't want to snowplow and drown. That's not fun. Now I know you also don't want to damage your wrist, because if you hold on, you get that significant distraction force across the wrist that can damage this complex. Another mechanism, so anything where that occurs. Another mechanism, I've been horseback riding since I was a kid. Same thing. You're not going to get tangled in those reins where you can have that distractive force that occurs. That can cause an injury. Drilling injuries can also stress this complex, particularly when there's pronation involved. And then any type of falls that land on that pronated and extended wrist can damage that complex. The way that the chronic degeneration occurs, the more chondromalacia type that we discussed with the ulnar impaction syndrome, are just that. Someone that has a pathology that has led to or change in their bony architecture where that ulna is longer. It'll lead to type 2 deterioration of this particular complex for the individual. Someone who participates long term in sports that have that high impact on the ulnar side, they tend to be more stick sports. Hockey, baseball, gymnasts sometimes, depending on which type of gymnastic activity they're participating in boxing, because that force is transmitted up through that complex. So that patient that presents with the pain in that area, we want to think about potential impaction where we can see actually tearing of that complex and then impaction on that lateral side of the wrist. Over time, that chronic leads to osteoarthritic changes. Tears to this complex can happen to different segments of it. All of them are going to occur with that ulnar-sided wrist pain and tenderness for the patient. If we palpate specifically between that pisiform and ulnar styloid process, is where that pain is going to be replicated. And then any type of weight-bearing activities, sit to stand, closing drawers, and then also when we resist that ulnar deviation and wrist extension, because it'll place excessive compressive force against these structures that are irritated. Decreased range of motion, they might have a popping and clicking with range of motion, particularly pronation. When that ulna attempts to translate, it'll lead to pain with grip also. If they're doing activities where they have like overhead pressing even with compressive force, working out can be indicative of this pathology. Assessment that's going to occur for this diagnosis: arthroscopy, getting in there, actually examining the different structures is the gold standard for identifying it. However, imaging studies can provide some insight, and there are a couple provocative tests if you're trying to differentially diagnose your patient. The PRESS test has a 100% sensitivity for the assessment of the TFCC tear. This is literally where you're going to have the patient perform sit to stand, where they're pressing down, they're in extension, and usually a little ulnar deviation naturally, compressing right through that complex when it should be functioning to stabilize and distribute the loads. It's stressed, and it'll replicate the pain for them. The fovea sign is where you're going to palpate that region right where that triangular fibrocartilage is located, and it'll be tender for the patient. And then the piano key sign is in more progressed cases where we also see involvement of stabilization of that distal radial ulnar joint. You'll stabilize the radius and then press against the ulna, and it'll actually be able to move up and down like you were pressing on a piano key. That would be positive. Management of this condition, we need to avoid repetitive motions that are placing additional stress on this area, pushing, pulling type of activities. So we tend to think of the big activities, but also think if you're going to pick up that bottle of water, you're pulling something, or a gallon of milk. So maybe teach them to use the other hand or slide it differently. When we're rehabbing patients, the research says we really need to take caution in how we're progressing the patients, because it may seem like healing's occurring, but a lot of the structures don't have good vascularity, a little too aggressive in mobility, and it allows them to regress. So particularly ulnar deviation, radial deviation, where we're stressing that region, pronation, supination, are going to be avoided until there's really good control of flexion extension. And then as you progress, even when you add those other motions in, you're going to hold off on the eccentrics, hold off on closed chain until more healing has occurred for the individual. If the patient is unresponsive, then surgery may be indicated to repair the structures in the area. Generally speaking, the research said that if after 3 months of conservative management there's not an improvement, then surgery may be indicated. Gamekeeper's thumb, we're moving now over to the palmar surface of the hand. We will look on the thumb side. Our ulnar collateral ligament, even though it's called ulnar collateral, it is at the thumb joint where we are looking, our metacarpophalangeal joint. It just happens to be more on the ulnar side than the radial side of that joint. And this, again, has had a lot of name changes over the years. Gamekeeper's thumb comes from when they would have a stick in their hand and they were, tending to the herd, and they might have a fall that creates that abduction extension stress that tears that ligament. Other ways that we see this more now, it might be called skier's thumb. Many individuals who hike or just walking, they're walking more with a stick for balance if they fall or lose their balance. Bikes, the handlebars based on the fall. Car accidents, if the thumb gets caught in the gear shift or steering wheel. Anytime we have that abduction injury, or someone who's performing a task where they have that repetitive abduction stress, not only can cause pathology to that ligament, there might be a slight little, we see here, avulsion fracture. And if you have a patient who's rehabbing from this, we use our typical grades of ligamentous injury and progression. If they continue to have that pain when you palpate the ligament and instability that persists, they might have developed what's called a Stenner lesion. This is where a little piece of this ligament, it is going to flip itself back under the muscle, and it's then not available to be reattached and heal itself, or some of the fibers may be stuck. Depending on the research, they say somewhere between 64 and 87% of the cases develop this, so that it might need surgical management if it's flipped back under the muscle. The progression and presentation of this pathology, we'll see that valgus laxity when we do a valgus force to that thumb. Lateral prehension will be weak because that also replicates that valgus force. So lifting, holding objects, grasping will be painful and weak for the patient. Progression, usually there's initial conservative management with a thumb spica, splint, or cast, progressing to active range of motion, and then adding that lateral pinch and opposition later on after more healing has occurred. Overall, generally speaking, the protocols seem to indicate about 4 weeks of the immobilization, 6 to 10 weeks of active and protective range, and then 8 to 12 weeks putting the forces back across that joint, because there are excessive forces with so many different activities across that joint. When we're rehabbing our patients, we're going to use patient-reported outcome measures to gain more information about how they are progressing and their functional limitations. Helps us not only see progressions, but also gives us insight on goals and what's important for the patient. The first tool that we will discuss is the photo focus on therapeutic outcomes for the elbow, wrist, and hand. This is a Medicare-approved functional status change assessment tool. It's going to utilize several different items that are scored. The patient will answer questions rating the functional tasks as to extremely difficult, they're unable to do them, or they have a low level of difficulty or no difficulty with performing them. Not only lifting and carrying things, it's going to be very specific in what it asks. Not, do you have difficulty opening things? Can you open a tight or new jar? Because that's very different. I have a family member I go over once a month, crack the lids on everything. So when asked by the doctor, do you have trouble opening jars? She always says no. Well, that's because I've already opened them. So again, specificity in our assessment, folding laundry, washing your back, and we're going to see that utilizing these scales, that it's a way to see progression for our patient. This is a standardized and validated tool. The Michigan Hand Outcomes Questionnaire is not only look at function, ADLs, pain, and work. I like that it adds questions about satisfaction, specifically how satisfied are you with, how you're able to use their hand. Very specific questions about sensory changes. Do you need to take it easy with the hand? Pain frequency questions are going to be included. And then it also adds an aesthetics component, because we may have patients with certain hand deformities or scarring, and how does the appearance of the hand or these pathologies cause contractures? Is it making them feel depressed? Is it not allowing them to socialize? And this might be our opportunity to look for outside referral and address things that will be most satisfying and impactful for our patient, other than just restoring function. The patient-rated risk evaluation is a mathematical calculation. You're going to add up the score for the pain-related questions, looking at rest, looking at the frequency of it. It's a 0 to 10 scale that's utilized. And then there are going to be questions about function, sit to stand, can you grab your toilet paper? And it's short and quick, scored out of 100. There was no clinically important difference that I could find. It seems like the benchmark is that a change of 10 is a true change. The Boston Carpal Tunnel Questionnaire has previously been referred to as the Carpal Tunnel Syndrome Assessment. It looks at symptom presentation for the patient as well as all the functional questions. What I found about this particular tool is that the minimal clinically important difference, they didn't come up with a number, but what they did find is patients that had a higher level of symptoms needed a greater change in their score to represent true satisfaction and improvement. They needed to make greater improvements to actually score it different. And then individuals who presented with diabetes, they really related it more to satisfaction, that they needed a higher value change in their score to actually report that they were satisfied with the improvements that they are seeing. As we look at all the different conditions that we discussed today, we spent a good amount of time really understanding the anatomy and the mechanics so that as we have the patients present to us, we can make sure that we're treating the appropriate condition and we know how to assess their progress and improvements and when we may need to feed back to the physician. And then we hit on some specific treatment pearls to consider as we are performing our rehabilitation with our patients.
Can trigger finger occur in the flexor digiti minimi brevis? The flexor digiti minimi brevis is one of the 4 muscles that are located in that hypothenar eminence on the pinky side of the hand. It's considered an intrinsic muscle of the hand. It's a short muscle which it originates and inserts in the hand itself. So it's originating down here on the hamate and the portion of the flexor retinaculum, and then it's inserting on that 5th digit proximal phalanx base. And it's just located in that area. It doesn't have a long tendon that's passing through that A1 pulley. So because it doesn't have a tendon that passes through that A1 pulley, it's not located in the region that's involved with trigger finger. The muscles that are, the tendons are attached to the long finger flexors that originate outside of the hand. So we tend to see this condition develop more specifically in the ring middle fingers and then the pinky of those long finger flexor tendons that are passing through that A1 pulley. Are occult scaphoid fractures common in PT? Occult just means that the fracture is not seen on X-ray examination. Not that it isn't suspected, but they may not come in with specifically the diagnosis of the scaphoid fracture. How often unconfirmed scaphoid fractures are really encountered in therapy is hard to say. I didn't come across any specific data that identified that. Individuals usually are presenting with pain and swelling on that radial side of the wrist, particularly the base of that anatomical snuff box, and they're going to be referred to therapy for that pain in that area. Maybe it's diagnosed as a wrist sprain after a foos injury, a fall on an outstretched hand. One report that I read did say that somewhere between 20 and 25% of clinically suspected scaphoid fractures, that's the instances where the patient did have some symptoms. They are actually not found on radiographs, even though the patient is clinically symptomatic. This is why we need to be very specific in our monitoring of patients that are coming in with that wrist sprain diagnosis from a traumatic injury, or those where they have De Quervain's symptoms presenting. It's that pain in that similar region on the radial side of the wrist, particularly those De Quervain patients or wrist sprain where the activity patterns don't really fit the pathogenesis of De Quervain's, and they also have a history of trauma. We might be suspecting a scaphoid fracture. Also consider that the patient with that wrist sprain that's just really not progressing, and then when you palpate, they're having that specific tenderness along the scaphoid, it might be suspect. Doesn't mean the physician missed something intentionally. It just means that they're really not that visible on X-ray examination. Generally speaking, what I found in the research is that the delay for visualization of specifically scaphoid fractures on radiographs is variable. Sometimes it takes between 2 and up to 12 weeks based on the source for it to actually show on the x-ray. This is why MRI is being recognized more as providing better accuracy for the diagnosis of these carpal fractures, and also why ultrasound is being explored as an option. Ultrasound can allow visualization of not only the associated soft tissue, but more importantly, they are able to see the cortical disruption at that fracture site of the scaphoid to help facilitate an earlier diagnosis. Why are scaphoid fractures a missed diagnosis for some patients? The clinical presentation of pain and swelling with a scaphoid fracture could be consistent with the wrist sprain along with the mechanism of injury. Also, when that fracture is not typically obvious on radiologic examination, there might be a lot of swelling in the area of the scaphoid, associated soft tissue trauma in the region. All of this can impair visualization of this complex anatomical region to begin with. The National Institute for Healthcare Excellence in the United Kingdom recently updated their guidelines, and they recognize these challenges in diagnosing the scaphoid fractures. They changed their recommendations to include that physicians should consider MRI as the first line imaging when that scaphoid fracture is suspected following a clinical examination. One study that I looked at, it analyzed 52 cases of negligence that were related to scaphoid fractures, and I am not claiming that it's negligent when it's undiagnosed. It just happened to be this one particular study that I think provide some information relative to your question as to why are they missed. I forget the exact country that it was performed in, but the information in the study was a little bit surprising. What they found in those particular cases that they looked at is that in the majority, the scaphoid fracture was not even considered as a possible diagnosis for the patients that were presented. When they went back and reviewed all the different medical records, scaphoid palpation wasn't even part of the clinical assessment to get that specific palpation at that base of the anatomical snuff box. And close consideration of the mechanism of injury was not performed to really see if it was that positioning that could lead to a potential scaphoid fracture. So diagnostic tests to get to that point of ordering even that MRI to rule out the scaphoid, they said in this study that it wasn't even a consideration to begin with. So choosing X-ray versus MRI really wouldn't have mattered. They also found that in the majority of cases that the patients were never told to seek additional care if their symptoms did not resolve or become worse. If they were diagnosed with that wrist sprain, that should resolve itself, particularly if they're having intervention. And we're going to look for that not progressing appropriately to be that red flag that possibly it's not just a sprain, that it is a fracture that just wasn't evident yet, or for whatever reason wasn't considered as an initial diagnosis. Again, not pointing fingers in any way. I think in these times where we have more direct access in therapy, and if you're receiving general referrals for wrist sprain, it's kind of a cautionary tale for us to be aware of this potential diagnosis and knowing the risk of avascular necrosis. We need to refer back to the physician indicating our suspicions if we have them as soon as possible. Do the Heberden's nodes change in size and shape? Heberden's nodes are the hard, bony prominences that occur on the distal interphalangeal joint in this region. They're going to occur at the proximal interphalangeal joint also in some individuals with osteoarthritis. In that case, when they're on the PIP, they're called Bouchard's nodes. In both cases, these are osteophytes that are associated with the osteoarthritis and the disease progression where there's deterioration of those joint surfaces, the cartilage deterioration. They tend to develop in more advanced cases of osteoarthritis of the hand. And from my understanding, they do not resolve because they are those osteophytes, those bony changes that we're actually seeing. Something else that you might also note when you do your visual inspection of someone with osteoarthritis are those little fluid-filled protrusions, either around the nail bed or on that distal interphalangeal joint. These might change in size, and they're called mucus cysts, which are actually a type of ganglion cyst. They are projecting out from that deteriorating synovial tissue. They tend to be a little firm if you were to palpate them, usually a round or oval shape. And if you go to try and move it or shift it, it's not movable under the skin. It's a protrusion out. And as the mucus cyst grows or are more persistent, there is a risk that they can press against that nail bed and start to create an indentation that you might see as the nail is growing out. But they are that projection from the synovial region that has deteriorated. So Heberden's nodes are bony, not likely to change once they're existing. Maybe they would get a little bit larger, but we wouldn't anticipate that they would disappear necessarily on their own from what I've read. What might come and go are more of those mucus cysts. Have you seen increased Guyon's canal symptoms with yoga? That's an interesting question to think about. Not particularly. I haven't seen that. But I guess if we were to consider the mechanism of injury and the pressures placed on the ulnar nerve with the development of Guyon's canal syndrome, where we have that excessive pressure in wrist extension over the pisiform hamate region where it passes through that canal. I guess we could think about that when individuals are in those different yoga postures, that usually when the weight is through the hands, it should be distributed through the palms and through the fingers, even if the wrist is in extension when it's being performed correctly. However, I've tried yoga. It's not easy. And, there are those postures that are a little harder to balance where someone might be taking more weight through their hands, or maybe they are extending excessively and weight bearing more over that pisiform hamate region because they don't have the range of motion elsewhere to be in the proper alignment. So I guess it could happen, though I wonder if being in a yoga posture or doing even one session of yoga or multiple over the course of a week, I wonder if it would be prolonged pressure for a long enough time to actually traumatize that ulnar nerve to result in the symptoms. I guess it would be something to think about if we're just going down the list of activities that someone's participating in when they do present with this diagnosis. It would be something to consider to see if we need modification to it. Maybe they need to use the blocks to have more appropriate posturing and shorten up the ranges needed at different area of their body. Might be something to think about.